All right, let's move to Bundgaard syndrome. This is also known as familial ST segment depression syndrome, a newly identified inherited cardiac arrhythmia, right? Sounds quite specific.
It is very specific and very recently described. This autosomal dominant inherited cardiac arrhythmia was first identified only in 2018. It was documented through collaborative research involving 5 families from 3 different countries, making it a truly recent discovery in the field of inherited arrhythmias.
What's the mechanism behind this persistent ST segment depression? Is it structural or electrical?
Bundgaard syndrome exhibits an autosomal dominant inheritance pattern with high penetrance, meaning if you inherit the gene, you're very likely to show signs. However, the cause of the gene has not yet been identified. That's a key area of ongoing research. Histopathological examinations haven't revealed consistent structural abnormalities aside from some nonspecific fibrosis sometimes seen in cardiomyopathies, but nothing unique or explanatory. Recent studies using advanced techniques like Cine ECG identified altered repolarization patterns localized specifically to the base of the left ventricle. Interestingly, researchers experimentally reduced the action potential duration and amplitude in these basal myocardial areas in healthy individuals, and this actually replicated the ST segment changes seen in affected patients. This strongly suggests a functional basis in electrical problem in a specific heart region rather than a gross structural one. Clinically, the ECG manifestations typically emerge during early adolescence. However, patients generally remain asymptomatic until approximately 50 years of age.
But they are predisposed to arrhythmias and commonly present later in life, with symptoms such as palpitations, syncope, cardiac arrest, or, tragically, sudden cardiac death.
What makes the ST segment depression in Bundgaard syndrome so distinctive on the ECG? How is it different from, say, ischemic ST depression?
Great question. In this syndrome, the ST segment depression is consistent and non-ischemic. That means it's not due to a lack of blood flow to the heart muscle like you'd see with a blocked artery. It shows no reaction to external factors like medication changes or improvement due to known influences. Instead, the depression typically worsens during physical activity, which is quite distinct. It is most significantly seen in leads 2, V5, and V6. One study found that 13% of affected individuals experienced atrial fibrillation, while another 13% had a history of aborted cardiac arrest or SCD. Ventricular arrhythmias were noted without any concurrent alterations in the QTc, ST segment, or T-wave morphology beyond the baseline depression, and they were mainly of a polymorphic nature. Paraclinical diagnosis involves looking for these patterns. Cardiac stress testing may reveal that persistent ST segment depression that worsens with exertion. Holter ECG is beneficial for evaluating the arrhythmic burden and for risk assessment. One study found that the majority of patients preserved a normal ejection fraction, though it was notably lower in men, with a quarter of male patients displaying EF under 50%.
Crucially, cardiac magnetic resonance imaging, CMR, reveals no specific structural abnormalities, reinforcing the functional electrical nature of the disorder.
How is this newly recognized syndrome diagnosed? Are there set criteria yet?
The proposed criteria include 1. Concave and upsloping ST segment depression greater than 0.1 mV in at least 4 leads, typically V3, V6, I333, measured 80 milliseconds after the J point in the absence of any secondary cause like LVH or drugs. 2. Often accompanied by ST segment elevation greater than 0.1 mV in lead AVR. 3. The ST segment abnormalities must be persistent, with no evidence of normalization over time. 4. The ST segment depression must be exacerbated with exertion. And 5. Evidence of autosomal dominant inheritance family history is key. Differential diagnosis includes Brugada syndrome, which typically causes ST elevation, long QT syndrome, and significantly left main coronary artery disease, which can also cause widespread ST depression, especially with exertion. Ruling out ischemia is critical. The treatment approach is mainly symptomatic at this point, focusing on addressing the patient's clinical symptoms like palpitations or syncope.
ICD implantation might be considered for patients who face recurrent syncopal episodes, or are deemed to be at high risk for severe arrhythmias based on family history or Holter findings, but risk stratification is still evolving for this new syndrome.
From a functional electrical disorder to a cardiocutaneous one,